For in-person LEICC meetings, attendees should be pre-registered on the New York City Department of Health Early Intervention LEICC page. For web-based LEICC meetings, attendees will find a link on the New York City Department of Health Early Intervention LEICC webpage. Meetings are open to the public, but the audience is not addressed at the meeting. For this web-based meeting, we will not be using the chat or Q&A features. For this web-based LEICC meeting, members of the public are asked to submit written public comments by emailing. Public comments will be read into the record at the end of the meeting. LEICC members will raise their hands instead of raising their cards to make comments. LEICC members should keep their cameras on during this meeting. Also, transcription is available for this meeting. Written meeting minutes will also be made available. LEICC members, would you please introduce yourselves? And start with Lydia.
Good morning, everyone. My name is Lydia Ledniak, and I am the Assistant Commissioner for the New York City Department of Health Bureau of Early Intervention. Welcome.
Caitlin?
Hi, I'm not actually on the council, the coordinating council, but I'll be presenting today from the DOE. I'm Caitlin Moore from the Division of Early Childhood.
Yes, thank you, Caitlin. Aaron?
Good morning, I'm Chris Trieber. I am the Associate Executive Director for Children's Services with the Interagency Council.
Mary?
Hi, I'm McCord. I'm the Director of Pediatrics at Health and Hospitals, GOSPA, the network of FQHCs that's run by Health and Hospitals.
Patricia?
Hi, good morning. This is Trish DeVito from the New York City Department of Education, Committee on Special Ed.
Patricia Gray?
Hi, good morning, everyone. My name is Patricia Gray, and I am the Director of Continuing Education at the Silberman School of Social Work and part of the academic partners with the New York City DEI.
Sundari?
Hi, good morning, everyone. My name is Sundari Periyasamy. I'm the Program Director for Pediatric Residency Program at Harlem Hospital, and I'm glad to be here this morning.
And Sonu?
Hello, good morning, everyone. I am Sonu Sangoi. I'm the Clinical Director at Achieve Beyond.
Everyone? I think
so. You forgot me. I'll just introduce myself. I'm Roseanne Saltzman. I'm the Director of Early Intervention at Up We Grow.
And
Thank you,
Kara
Roseanne.
Chambers. I'm the Director of the Legal Aid Society's Education Advocacy Project.
Thank you very much. And that's everyone. Okay. So now, Assistant Commissioner Ledniak and I would like to thank Christopher Trieber for serving on the New York City LEICC for the last 4 years. Thank you for all your advocacy on behalf of the Early Intervention Program, children, families, and providers.
Yes, Chris, thank you so much for all you've done. This is Chris's last LEICC meeting. So we just wanted to acknowledge everything that he's done, and I mean, broadly, but also over the last year and a half during COVID and his leadership during this time.
Thank you.
Okay, we will now approve the minutes from the last LEICC meeting. Will someone make a motion to approve the minutes?
Approved.
Thank you. Will someone second the motion?
I'll second the motion.
So now we are going to launch a poll to vote to approve the LEICC minutes. So the LEICC members should vote as they approve, oppose, or abstain from approving these minutes.
I vote to approve.
You can use the poll. You just see it on your panel.
I just wanted to say while everybody's working on the poll, Jessica Wallenstein is here with us as well from the Department of Education, Early Childhood. She's just having some tech issues, so welcome, Jessica. Okay, I believe everybody has a vote. Has everybody voted at this point in time? Yes, okay. We're gonna close the poll. And okay, I think we're good. The minutes were voted as approved. So this is new for us. We're using a poll for the first time, partially because Araceli is not here to masterfully take us through this process, but the minutes have carried.
Thank you.
All right, great. Thank you.
Okay, so now we'll move on to our next agenda item. So we will have Assistant Commissioner Legnac present on the SEICC report, the governor's budget, and the EI program update.
Okay, thank you, Liz, and thank you everyone for joining today. I am going to be talking about the governor's budget first, and then I'm going to move over and speak about the State Early Intervention Coordinating Council, as those two items are connected, and then we will give some program updates. So the 2021 2022 governor's budget proposed to cut the early intervention appropriation by over $10 million and to continue withholding 20% of every payment from the state to municipal governments for early intervention services. I'm happy to report that neither one of those proposals made it into the final budget. Thank you for your advocacy on that. The governor's budget also made a number of programmatic proposals, which included establishing a telehealth rate in early intervention at the facility-based rate, not the home and community-based rate. And it also made 3 additional proposals really around group services in early intervention, around the elimination of extended sessions, the elimination of back-to-back group services, as well as the elimination of push in and pull out services while an early intervention group is in session. So what I just want to clarify is those proposals are really not, those are more policy and programmatic proposals. And so those definitely are still on the table. And you will see that sort of coming through as I do this State Early Intervention Coordinating Council report. So I will just launch into that. So as you can see in front of you, these were the State Early Intervention Coordinating Council agenda items. I will only be providing specific item updates on the Early Intervention Program regulations, the Provider Workforce Capacity Subcommittee update, and an update on the EI Hub. The rest of the materials I have shared with the members of the LEICC. I encourage you to look at them. Particularly, there was an interesting data report that the State Early Intervention Coordinating Council put out. So as part of the SEICC report, the state walked committee members through the following proposed modifications that are being planned for early intervention regulations. So the first is on section 69-4.1. This is the definition section. A new definition will be established for collateral visits as well as group early intervention services. The word directed will be added to the term family assessment. 4 new mental health provider types will be included in the section of EI qualified personnel, and school psychologists will be completely removed as a qualified personnel in the early intervention program. Section 69-4.3 will clarify that there are follow-up screening and diagnostic options for an infant who has failed a newborn hearing screening. It is still to be determined really what this means. Does it mean a first hearing, a fail of a first hearing screen or of a second hearing screen? So once the regulations are put out, we're going to really kind of dive into that because that may have some beneficial program implications for us. These regulations also seek to align the definition of elevated blood lead level with other state standards, which is obviously a positive thing. Section 69-4.4 updates that timely completion of service coordination training must occur within 4 weeks following departmental approval and prior to the delivery of any service coordination services. Section 69-4.5 amends the number of documented clock hours of experience needed for the delivery of services to children under 5 from 1,600 hours to 1,000 hours. This modification was specifically recommended by the Workforce Capacity Committee because we are trying to improve the capacity and availability of EI services in the state. This section further calls for an amendment to the section with regard to discipline-specific quality assurance plans. That requirement is being eliminated, and new early intervention providers will only be required to keep and provide an overall QA plan, which will reduce the burden on providers. This section will further be amended to require that new agencies have all staff employed before being granted a state approval, which will give us a more accurate understanding of what system capacity really looks like. Section 69-4.8 will be amended to clarify that an evaluation instrument must be administered following all protocols in the examiner's manual. Section 69-4.10 will be amended to clarify that frequency means the number of days or sessions per week that an early intervention service will be provided. Section 69-4.2 will amend and clarify that notification of potential eligibility to the CPSC, or rather parents' objection to that notification, must be furnished in writing. Current regulations allow for that objection to be issued either in writing or verbally. Section 69-4.26 will be amended to clarify that written orders, prescriptions, apply to multidisciplinary and supplemental evaluations, which will be a change for us. This section will also clarify what is required for completion of session notes. Section 69-4.30 will be amended to only allow supplemental evaluations when they are authorized at an IFSP meeting. The only exception that these regulations contemplate is a supplemental audiological evaluation for infants who are referred for newborn hearing screening and are suspected of having hearing loss to determine whether hearing loss is present. Section 69-4.3 will further be amended to specify that service coordination should be delivered in accordance with the child's IFSP. Further, there will be amendment to clarify that a basic visit must be a minimum of 30 minutes in duration. This section will further be amended to provide some modifications to the way that group services are billed for an EI. Group services will be up to 120 minutes per day, as specified in an improved IFSP. Group service sessions will be a minimum of 60 minutes in length and a maximum of 120 minutes in length in accordance with the child's IFSP. These regulations do contemplate some kind of process for early intervention officials to provide waivers for this. So the devil will be in the details on that. Furthermore, group size will be 2 to 6 children, with a maximum number of children participating in a group that requires a one-to-one aid to be limited to 4. Groups are provided by a minimum of 1 approved qualified EI provider and an assistant. Children participating in group early intervention services cannot also receive individual services, such as push-in or pull-out services while the group is in session. The State Department of Health did not provide a date for when this regulatory package will be posted for public comment. Once it is posted for public comment, we will obviously do a thorough analysis of all of this language and obviously all of its implications onto the program. Currently, the status of this is that it has been approved or reviewed by the New York State Department of Health's Regulatory Advisory Committee. So more to come on that. But I think what you are seeing here is some of those programmatic initiatives described in the governor's budget really manifesting themselves here. The next thing I want to provide an update on is the provider workforce capacity subcommittee. As you know, the goal of this group is to develop recommendations to the department to increase provider workforce capacity to deliver EI services. And the State Early Intervention Coordinating Council revised the charge of this subcommittee to add telehealth to its charge in terms of how can telehealth be utilized properly in the early intervention system if we are to make it available. At the last SEICC, the committee voted to adopt the following competencies for the delivery of evidence-based evaluations and services in the New York State Early Intervention Program. I don't think these are new to any of you. This is something that the city has been working on for a few years. So we are very happy to see this being accepted at the state level. And they include typical and atypical childhood development, birth to 3, multicultural and diversity factors, particularly in evaluations and services, understanding family and child dyad as it relates to routine-based interventions, evidence-based family-centered best practice, and reflective practice and supervision. What you will see missing here is in New York City, we had a 6th competency, which really focused on workforce, on field work placement, because as you know, the way that the regulations are structured right now, they really do not envision field work placements taking place in early intervention settings, which obviously doesn't really help if you want to ensure that folks are entering the field trained up. But this field work placement was taken out as a separate competency, but included as a separate section to highlight the importance of it as a theme running through all of the other competencies. So thank you for all of your support on this over the years, and particularly to the academic preparation subcommittee that we have here as part of our LEICC that really helped to develop these and formulate them. The other thing that happened at as part of this subgroup is that the subgroup finalized the telehealth surveys that the State Department of Health wants to do statewide. I am happy to report that the New York City telehealth survey was used as a sort of starting point to develop the state version, and we are going to have a really wonderful presentation today on the results of our telehealth survey that we have done. Okay, so EI Hub implementation. As you all may have seen, the EI Hub learning management system has launched. And folks are really encouraged to get in there and start taking a look and availing themselves of all of the trainings there. The state did clarify that between the decommissioning of NICE and the launch of the EI Hub, At first, we thought that there was going to be a 2-week cutover period. Now it looks like that period is going to be 3 weeks, so a month. So we are very interested in understanding what that's actually going to look like and what the impact is going to be on our service system, because we are 24/7, we're constantly working. So it's going to be really interesting to understand how that's all going to work. Just want to reiterate again that the May 2021 implementation date for the EI Hub has been delayed. At this point, we are expecting an implementation date more in the fall or in the winter. Once the EI Hub is launched, NICE will remain available in read-only state for 6 months before being fully decommissioned. I want to pivot over and talk about COVID-19 program updates. This really lays out where we have been and sort of sets the stage for where we need to go. Early intervention was deemed an essential service during New York on pause. As of March 24th, 2020, all EI services in New York City went remote. On June 22nd, we released a return to in-person service action plan. And on July 6th, 2020, in-person home and community-based services, facility-based services and evaluations could be provided in person. On October 21st, 2020, early intervention group services resumed with multiple transportation options. Currently, all early intervention services are available utilizing teletherapy and in person, with some services only available in person, such as respite. Teletherapy remains the recommended service option in New York City due to the ongoing pandemic. And in order to support the resumption of in-person services in home and community-based settings, we have released a fairly detailed reporting protocol for all early intervention providers, which outlines the information that providers must submit to the Department of Health when there is a confirmed case of COVID-19 in a group, home, or community-based setting. And this guidance also provides messaging to families regarding mandatory modifications of service delivery from in-person to teletherapy. What I want everyone to hear and what I want us all to echo is that early intervention services are effective and they can be delivered safely during COVID-19. Families should not wait to refer their children. The earlier we can get a family services, the better off they will be. All early intervention providers must have a plan that complies with New York City and New York State guidance. And there are early intervention specific precautions in place, including face covering, physical distancing, hand hygiene. We have really put out a lot of guidance around the use of toys and other materials. There is increased cleaning, disinfecting, and ventilation, and there are also required screening protocols. So, we know that, parents may have wanted to wait to start EI, but at this point, the time for waiting is over. We want full utilization of our services and our system. So, and we are going to be presenting a lot more about what we're doing in our outreach efforts in order to ensure that families feel safe and we are getting our referrals to where they need to be. The latest COVID-19 updates, early intervention therapists and teachers are eligible for COVID-19 as of January 14th, and Kathy Canary, our medical director, if she can sign on, will provide a great presentation on COVID-19 vaccine. We have also released guidance on the changes to quarantine duration from 14 to 10 days. We have updated information about the expectations for quarantine for individuals who have been fully vaccinated and are asymptomatic. But what I want to make sure everybody's clear on, even if people, are fully vaccinated, Regardless of their quarantine status, all individuals exposed to COVID-19 must continue daily symptom monitoring for 14 days, observe all COVID-19 precautions, and self-isolate if any symptoms develop. We also released additional information regarding recommendations for monthly COVID-19 testing for essential workers with frequent direct contact with the public, such as EI providers. And we are probably going to be sending out some updated guidance, I think, if not today, then on Monday, with additional guidance and refinements of these expectations as the system and general public health authorities gather more data on the implications of having folks fully vaccinated. That is my update. Are there any questions? Yes, Dr. Periasamy.
Yeah, I just had a question about how many percentage of like the therapists are vaccinated at this time? Do we know that number?
We do not know what that number is, but our conversations with provider leadership indicates that that therapists are aggressively getting vaccinated.
Okay. The reason why I comment on that is like the parents might feel little kind of better if they know the therapist is already vaccinated. The other question I had is about the group therapy. Is there like how are they grouped by age or but the extent? How are they grouped?
Early intervention group services are, they are subject to a multitude of regulatory requirements, including, grouping by age. There are specialty groups set up to address the children's specific, disability concerns, and all of that is very heavily kind of guided and regulated. And these proposed regulations will, the broadest interpretation is that there will be fewer children in a group now than the current requirements contemplate. I can provide you with some links for you to kind of read up on all of the various group requirements.
Thank you.
You're welcome.
Lydia, I have a question. Just to get back to the state early intervention report. So did I understand that there were going to be no supplemental evals until after the IFSP was formulated? So in other words, a core would be done and that's it. And then once the IFSP happened, additional supplementals. Is that correct?
That is my interpretation. However, this was really just a presentation that the state did. So once the full language is available to us, we will be doing obviously a fuller analysis and really digging into all of these various implications. But based on what this says, yes, that is, and my understanding is that the concept of a core may no longer be a construct. It may just be an evaluation to establish eligibility, and then whatever supplemental evaluations are needed later on. And you can kind of, think about this in two ways. Since the state is also going to be requiring an order for MDEs and supplementals, which obviously is going to layer on more time, this may actually be a better approach because it allows us to get the family through the process as quickly as possible and then do additional supplementals after. So.
Okay, all right. And there was something else in the LEICC report that you didn't really speak about, but I was wondering about. It talked about the need for a parent to sign both a session log and the session note, or whatever the municipality required, that they were going to clarify this a little bit. I was just wondering if you had any more insight. So the parents have to make 2 signatures then for every session? Is that how you understood that?
In New York City, parents have to sign both. That has been, we have had our session note requirements for a long time. and we utilize it to effectively monitor our system. And we also believe it's appropriate for parents to receive receive these things right after the session is completed so that they know what just happened at the session and what they need to work on. So that is what we currently do in New York City. I think that once we fully understand these regulations, we will consider them as they relate to our current standing requirements.
All right, thank you.
Welcome. Tara?
Lydia, I just had a quick question about whether the agency has any strategies or plans in place to bring that the level of the referral rate back up to pre-pandemic levels, and how the rest of us on the LEICC can help with bringing those rates back up to what they were before.
So we have I think the entire rest of the LEICC presentations are focused on getting referrals up.
Okay, great.
And so yes, and I think that, if members of the LEICC, and I know a lot of you are already involved in work to streamline referral processes and the like, and if others have ideas for how you would recommend that we do that and take on additional and have additional recommendations, we are absolutely open to hearing that from all of you, because this is something that is not just something the department does. This is something that all early intervention stakeholders obviously care all deeply about. So after we're done with this set of presentations, if there are other thoughts and ideas, then please let's talk about that, offline, and consider how we can make that happen. I think we're very open to all of your ideas around this. So thank you for that. Okay, so I see that. Okay, so Roseanne, okay, and Kara, your hands are up from before. Okay. All right, so let us move on. Oh, Liz, yes.
Yes. So we have Nora Puckett, Director of Administration and Data Management. Will be presenting on the data report and provider oversight activities.
Good morning. So here we are. So we're starting off with the chart that we have been looking at since last summer, which is comparing what's happened in 2020 since COVID with the year before, 2019, as a baseline. So you can see here the bars are 2020 and the red line is 2019. And you can see we started off the year almost exactly where we were last year. And then we had this precipitous drop, obviously in April and May. And we just really started to get back and hit our stride really in late summer. And we've gone up since then. And at the end of the year, we were pretty close to where we were in 2019. We're going to be looking at more recent referrals in some of the next slides, but this really shows you for that year, calendar year 2020, this is how it played out and how we wound up making our recovery. Next slide. This slide is something different from what we usually present. So normally we share sort of internal EI data, but in this case, we took the opportunity to compare ourselves to activity in other areas of early childhood to see what they were doing during the same period. So that blue line represents children being vaccinated, children under the age of 24 months in New York City. And the red line is EI referrals. And you can see how closely they track, with EI referrals really following behind to a great extent. And that's not surprising because we know that physicians and well child visits are a very common source of referral. So this really underscores how important healthcare is to us. And as you know, we've been doing a lot of work with the pediatric community, particularly H&H, and Mary and Kathy are going to be presenting on that later in the presentation. Next slide. And so here we are with our more traditional data presentation. Before we go into this, I want to talk about years because that earlier slide talked about the calendar year, which is what most people think about. And you can see that the COVID period in a lot of ways coincided with a calendar year. But in general, we report our data on a fiscal year because for New York City, we set goals on a fiscal year basis. And the fiscal year is July through June. So that when we talk about FY21, we're talking about a period that includes the second half of calendar year 2020. So if you think back to that earlier slide, you know that summer and fall, we were still very much in recovery mode. So when we look at this data, you need to keep that in mind about 2021 is actually really spanning those two time periods. So here with referrals, what you see is that obviously 2020 FY was greatly impacted because the last 4 months, March, April, May, June, were in the most intense of that COVID period. And so they were down from 35,000 to 29. What you see in 21, FY21, is that the numbers are going up, but they still included those really 4 to 6 months where we had just resumed in-person services, and a lot of families and therapists were easing into that pretty slowly. So we see that the numbers are still down. It looks like we may get up to where we were last year, but we're probably not going to see the full recovery until FY22. What we do see here as well is, this is by borough, what you can see is that the distribution across boroughs stayed the same. So we didn't see any particular borough more impacted than another, which is interesting. Next slide. And this is referrals by race. So it's the same story, but again, what's really interesting is that total consistency in distribution. So despite the fact that we know that COVID had some differential impacts, in terms of EI referrals, it was pretty consistent. Next slide. So this is children receiving services. And the situation here is different than referrals because referrals are a one-time event. So what didn't happen in those 4 months didn't happen. But services, children are in for many months, usually more than a year. And we know that most families that were already in service stayed with us. Either they got teletherapy or they took that 2-month break and came back for in-person, but most of them, the majority, did not leave. So in 2020, we didn't see that much of a difference because those children stayed with us and they'd been here since the previous fall and summer. We see it more in 2021 because of that drop in referrals, right? That is where it's playing out here in the number of children that get into services. Again, what's interesting is there's really not an impact on distribution. We weren't seeing one place in New York City that was more impacted than another. Next slide. And the same thing here. Really, with race, we didn't see that that was differential. It was just across the board. Next slide. So this is any type of service, meaning you only got service coordination, you only got service coordination and evaluation, or you went all the way through to services. And as you know, we always like to include this to demonstrate how many families we have some degree of interaction with, even if they don't go on to services. So here, what you see in terms of the story is that it's very, very consistent with services in terms of a greater impact in 21 actually than in 20. And no real impact on distribution. Next slide. And again, with race, you're really not seeing the impact on, differential across race. Next slide. So this is our waterfall, and this is about children's experience in EI. And to remind you of how this works, the question is, of children who left the program during this year, they finished. How far had they gotten? What happened to them while they were here? Were they only referred? Were they evaluated? Were they eligible? Or did they receive services? This looks at the progress of children in the program or referred. And so what that means is you don't see a COVID impact because this isn't about volume. Where you might have expected to see a COVID impact is perhaps if children were less likely to make it through the process. But what you see is that really wasn't the case. there was a very small 1 to 2% drop, but overall, that really wasn't it. If children came, they made the progress they would have in previous years. Next slide. And then finally, insurance status. So we always talk about this because we really like to flag that insurance is a really important way to support the program. This is completely consistent with previous years that almost 10% of children do not have insurance recorded. And we just do not believe that is accurate in terms of reflecting how many children just don't have insurance. This is about service coordinators not entering it. And we always want to emphasize that. In this time of COVID, we also want to mention that for all of COVID's economic impact, there's actually not really a change in the distribution of private insurance, Medicaid, or none recorded. This is completely consistent with previous years. So again, this was not impacted. So that is the story, and I'd be interested to take any questions. Okay, provider oversight activities. So provider oversight. As you know, in response to the pandemic, we stopped doing on-site audits back in March, and we did not continue them. What we did instead was to shift to calling families to verify that services were still happening or had switched to telehealth during the COVID period. And we called more than 9,000 families, and to put that in perspective, about 17,000 families were in service, so we reached really more than 1 in 2. And the vast majority had made the transition, and where we found problems, we went back to providers. And we wound up going back to almost every provider to raise whatever issues we were seeing. After that, we've been conducting sort of targeted file reviews, and the most recent that you may be aware of was looking at session notes for quality and compliance. Next slide. But we're ready to go back, and we're going to do our full monitoring in the sense of every agency this year. So we'll be sending out the announcement letter early next week, and we will be starting off in May. Now, we're not going to come on site, so we'll be asking to have materials sent to us. We're going to be looking at all of 2020. So a lot of providers have asked about, what does it mean to audit on the COVID period? And the answer is, we are looking at the COVID period. We are not giving a pass just because there was telehealth or there were challenges. We may be looking at a smaller set of monitoring indicators, but we may also add some indicators that are specific to telehealth and to challenges during COVID. Now, we know that there were challenges and it was hard. And the balance we're going to strike here is we're not going to be giving out the traditional reports with a rating and a corrective action report required. We're going to send out a letter of advice. We're going to identify everything we saw and how it correlated to performance in the past by this agency, but very specifically, what were the concerns, especially if they were around things like telehealth, where we know there's a lot of need for learning and growth and improvement. So agencies can look forward to getting full feedback on their performance during 2020, including the pandemic period, including the telehealth only period, but they will not be penalized for it. Next slide. And questions on that or the data at this point? Okay.
Thank you, Nora.
Thank you. Now we'll have Dr. McVeigh, who will be presenting on the teletherapy survey results. I'm really excited to hear.
Good morning, everyone. Since the last time that we met, the Bureau of Early Intervention has fielded surveys of agencies, interventionists, and families to learn about their experiences with teletherapy. We've completed data collection and are in the process of analyzing the data. Today, I will give you a sneak peek at some of the initial findings. Data, next slide, please. Data collection occurred over about 6 weeks in January and early February. Participants were recruited through emails to agency leadership, outreach to professional organizations, and by text to those families who had enrolled in our Text to Family initiative. We used SurveyMonkey and built questionnaires with both open-ended and fixed response questions and included many comment boxes to give respondents lots of opportunity to share their experiences with us. I will be sharing with you some of the top-line findings from each survey, starting with data from the English language version of the family survey. I should start by noting that the surveys are not statistically representative. These were convenience samples, and the people who responded to the surveys probably have stronger opinions than those who did not, and their opinions may be different from the population overall. So as you view the results, please keep in mind that the percentages are among the respondents to the survey and not necessarily among the entire population. So starting with overall satisfaction, 65% of respondents to the English language survey of families expressed satisfaction with teletherapy, and 29% would like it to be a regular part of their service plan in the future. When we looked at the open-ended responses, we saw three groups: those who were enthusiastic about teletherapy in and of itself, those who were appreciative that teletherapy made it possible for their child to continue benefiting from EI services during this challenging time, and those who had negative opinions about teletherapy as a mode of EI service delivery for their child. Next slide. We were also interested in learning about whether service coordinators had sufficiently prepared families for teletherapy. Respondents were asked, did your service coordinator provide a quality explanation of what teletherapy is and your role in teletherapy? 68% of responding families indicated that their service coordinator had done a good job of informing them about the service. Next slide, please. Satisfaction with teletherapy among responding interventionists was higher than among responding families, ranging from 69% among occupational therapists to 85% among physical therapists. And it will be interesting in the future to try to unpack the difference between the physical and occupational therapists. Next slide. When asked what additional supports and resources interventionists would need to make teletherapy a part of their practice, 65% identified a need for training. Professional tools and videos were identified as needed by 40 to 45% of respondents, with links to internet resources being seen as less important. There was not much enthusiasm on the part of the interventionists for either ongoing clinical supervision or observation of sessions. However, several respondents to the agency survey did mention remote observation of sessions as one of the benefits of teletherapy. Next slide. Respondents to the agency survey were the most enthusiastic group, with 89% wanting to continue offering teletherapy. Agency respondents strongly concurred that teletherapy improved their ability to serve hard-to-staff neighborhoods and to accommodate non-traditional hours. In summary, there is support on the part of families, interventionists, and agencies to continue teletherapy as an option for delivery of EI services going forward. Our next step is to better understand and address challenges identified by dissatisfied respondents and to continue to compile and develop resources to support agencies, interventionists, and families going forward. I hope you enjoyed this brief tour of the findings of our teletherapy surveys. Does anybody have any questions?
Okay.
I don't see any questions.
Thank you, Tina.
Thank you.
Do you have any?
I just wanted to say that I'm really happy to see some of those numbers in the work that I'm doing. Our school, the Brooklyn College Early Childhood Center, is virtual right now. And I had reached out to a lot of the parents, and we have about maybe 7 children that are receiving services. And when I spoke to those parents, they had really positive things to say about the teletherapy. And I'm glad to see that it's reflected in those numbers also. And they didn't, you know, I've even seen see it sitting with the children on the video and helping them through, you know, a music lesson or, you know, a lesson with the teacher. So it was really, you know, nice to see that. And I'm glad that parents are really, they didn't, you know, fall into the crack of COVID, you know, and make sure that all the services continue. So thank you so much for that.
Chris, did you have a question?
I wanted to know, one is, was there any analysis either like by borough or zip code in regard to the satisfaction? And the reason I'm asking is because I think there is a concern among some advocacy groups and others that in the underserved communities, they do not want teletherapy to become the real or the only option for families as an alternative. And I think there's real concern among some communities that that could happen. So that's what I was just kind of wondering.
So we did collect zip code, but we haven't yet collapsed zip code into borough, for example, or stratified or collapsed it into neighborhood poverty or some other aggregate that would be easy to understand the answer to your question. But that is on the list of things to do.
And we certainly agree that we don't want teletherapy to be the only service option, but particularly when we think about it from an equity standpoint, we do not want children living in certain communities to only get teletherapy. The goal of this was to see, is teletherapy a viable option to have in the system, and what supports and services are needed to actually make it a high quality service option. So, you know, I think that your concern is well placed, and I think we can take a look at zip code data to see if there's anything there to share with you.
Okay, thank you.
Welcome. All right. Thank you, Tina.
Thank you.
Okay.
Now we'll have Dr. Canary, our medical director, will be presenting on the COVID-19 vaccine.
Let's see. Just 1 second. I want to see if I can. Okay. Just 1 second. I want to see if I can find Kathy here. Kathy, are you dialed in? Oh, all right. Well, we are going to see if we can figure out Kathy's technical issue. But for now, I think we can skip to our next presentation.
Okay.
Sorry about that. Let me just one second, please. Kathy, can you try speaking now?
Yeah, can you hear me?
Yes, we can hear you. All right. Wow.
Oh, look at that.
What
I've been dialed in the whole
a-
time and following. Okay, so I'll just need you to advance my slides, Leah, because I'm looking at my own set, but anyway. the joys of working from home, as I'm sure we can all attest to, having done it for a year. So thanks very much. I'm just going to talk briefly about COVID-19 vaccines. And if you can show the next slide, Lydia, this is just a list. My information comes mainly from the CDC and also from the New York City Health Department's webpage, which provides a wealth of up-to-date data and information about COVID and vaccines, as many of you probably know, but you may want to check in there periodically and see what's happening. On the next slide, you'll see that we have really good news. Actually, as of this morning, the web page showed that more than 4.7 million doses of COVID vaccine have been given to New York City residents so far. And there are over 5 million doses actually in the city. So my guess is that by the end of Sunday, by the end of the week anyway, we will have passed the 5 million dose mark. And as you also probably know, as of this past Tuesday, all New Yorkers 16 and older are eligible for vaccines. So that's great news. Next slide, please. So one of the things that's really significant about vaccination is that it's one of the two ways that people can develop immunity or protection against a disease. So one way you develop immunity is by actually getting sick with a disease, in this case with COVID-19. Vaccination allows you to be protected without experiencing, the illness itself. So it's not clear with respect to natural infection. It's not clear how long your natural immunity lasts, although with the current guidance that's being put out, it suggests that, immunity lasts for 3 months. The COVID vaccines in clinical trials demonstrated high efficacy against severe and symptomatic COVID-19. There's limited information, although it's an active area of study, as to how much vaccines can reduce transmission of disease between people, how long protection lasts after you've been vaccinated, and how efficacious they are against these emerging variants. So that's, as I said, areas of active study. So next slide, which is better, natural infection or vaccination? Both of them result in protection against disease, but certainly my recommendation is to go with vaccination. You're more likely to be protected against the development of severe symptoms or hospitalization. You're less likely to die from COVID if you've been vaccinated. And, you're most likely protected from long-term side effects. Just last week, there was a morbidity and mortality weekly review. It comes out from the CDC. It studied about 4,000 participants who were first responders or healthcare providers who were some of the first to get COVID vaccine. And so they found that among those who were fully vaccinated, they were 90% less likely to get infected with COVID over the couple of months of the study period. Next slide, please. So the other thing about vaccination is that it helps develop herd immunity without people having to get sick in order to develop herd immunity. And what that is where an entire population, enough people, become immune to a disease to make it spread unlikely. So this protects everyone, even people who may not, for some reason, be able to be vaccinated. So with vaccination, you can get to herd immunity without, overwhelming the healthcare system and without a lot of people getting sick and dying. Next slide, please. So you may think that if you've heard or seen one vaccine, you've seen them all, but there are actually several different types of vaccines. And the ones that kids get, there are 4 main types of them. One is live attenuated vaccines, which use a weakened form of the organism. And others are inactivated vaccines, which use a killed form of the organism. Yet another type uses a piece of the organism, and a 4th type uses the toxin produced by the organism. This is like tetanus shots of this kind of vaccine. The COVID-19 vaccines use an entirely different technology. These actually provide the instructions for our cells to make a harmless piece of the spike protein that's found on the surface of the SARS-CoV-2 virus. So the 2 mRNA vaccines use messenger RNA to deliver the information, kind of like sending an email and then deleting it. The viral vector vaccine, which is the Johnson & Johnson, uses an inactivated or a killed form of one of the common cold viruses to deliver the instructions to our cells. So the cells receive the instructions, they make the protein piece, they display this protein piece on their surface, and then your body recognizes that protein as being foreign to it and not supposed to be there. And so the body then begins to build an immune response and makes antibodies, like what would happen in natural infection against COVID-19, except that you didn't have to get sick with COVID in order to get this protection. So at the end of the process, our bodies have learned how to protect us against future infection. Next slide, please. Vaccine development, I think it was called Project Warp Speed or Operation Warp Speed, which may not have been a great term, but you know, the reason the vaccine development was able to happen so quickly is for a couple of reasons. And one is that a process which is usually sequential, one step at a time, everything gets reviewed, then another step happens. Steps happened simultaneously rather than in sequence. Science is built on many years of research from other vaccines, including research on vaccines for other coronaviruses. The federal government provided special funding so that development, testing, and production could all happen at the same time. As I said, things happening simultaneously rather than sequentially. The testing process occurred as it always does, with 4 phases of clinical trials. So phase 1 involves less than 100 people. Phase 2 involves several hundred, phase 3 involves thousands of people, and then phase 4, which is where we are now with the 3 vaccines that are available, this is where continued studies and monitoring go on. So in addition to the clinical trials, the drug companies started manufacturing vaccines so that they'd be ready for distribution if an emergency use authorization was issued. And I can attest to the fact that the federal government and state and local health departments and healthcare providers have been working for months on the logistics of delivery and storage and giving vaccines and documenting vaccines and providing the supplies and all of that. So a lot has happened over a short period of time, but largely because things happened, like I say, simultaneously and with a lot of funding behind them. Next slide, please. The Food and Drug Administration monitors the development of vaccines from beginning to end. They analyze clinical trial data to decide whether to allow a vaccine to be used, and then they continue to monitor vaccine safety data, which is that phase 4 of clinical trials that I mentioned before. In an emergency, like with COVID, the FDA may allow vaccines to be used before they're officially licensed, and they do this by issuing an EUA or an emergency use authorization. So an EUA can only be issued if the evidence strongly suggests that the benefits outweigh any risks to patients and there are no adequate, approved, and available alternatives, which is what happened again with COVID. Next slide, please. So these are the 2 mRNA vaccines. One is produced by Pfizer and one is produced by Moderna. For both of them, the efficacy data were almost identical in clinical trials. Data were consistent across age, gender, race, and ethnicity, and the U.S. study populations, more than 30% of those were from communities of color, and the trials were large, only, over 30,000 study volunteers for each of them. The 2 are pretty similar. They both involve 2 intramuscular doses. For the Pfizer's, 2 doses have to be given a minimum of 21 days apart, whereas Moderna's are a minimum of 28 days apart. Pfizer's a little harder to store. You have to use ultra cold freezers, and so it tends to be used at major medical centers where they have these freezers. And Moderna's a little bit less fragile, so that actually is the one that's been used in the health department's vaccine clinics. Pfizer is the only one that's authorized for use in individuals 16 and older, whereas Moderna can only be used for folks 18 and older. Next slide, please. The Johnson & Johnson or Janssen vaccine was just granted an EUA about 6 weeks ago, and you can't compare efficacy data because It was studied at a later time frame than the Pfizer and Moderna studies. More variants were circulating and a different population was used. But the clinical trials indicate that Johnson & Johnson is clearly efficacious at 28 days after vaccination against severe illness and hospitalization. It's also an intramuscular shot, and it's also only authorized for people 18 and older. The thing that people like about the J&J is that you only need one shot. And it's also, particularly compared to Pfizer, but also compared to the Moderna, it's even easier to store and transport. So it's ideal for certain subpopulations who may have difficulty traveling to a vaccination site or who may have difficulty getting there twice. So it has, at least early on, it was used targeting like homeless populations and homebound folks. Next slide, please. So the side effects to the 3 COVID vaccines are similar, and mild to moderate reactions are not uncommon. Probably the most common is pain or discomfort at the injection site, but some people may experience some systemic effects like fever, chills, fatigue, body ache, headache, muscle ache. Most of the side effects appear within the first 3 days and resolve within a couple of days. Side effects appear to be more common in younger than older recipients and more common after the second dose than after the first dose. And I haven't seen any explanations for those yet. And, you just treat those with typical pain relievers like Tylenol, Motrin, or Advil. Next slide, please. So you've heard a lot in the news about COVID variants, and if you look on the CDC site or the DOHMH's website, you'll see lots of information about those. Viruses mutate regularly, and SARS-CoV-2 is no exception. So we expect changes in its genome, and we're actually familiar with this phenomenon because influenza mutates regularly also. And so flu shots every year are different depending on which strains or variants are expected to be most prevalent in a particular flu season. Several recently identified variants appear to be more easily transmitted than other strains. So people might say, well, they're more, you're more contagious or they're more infectious. Whether these variants can evade the immunity that's induced either by vaccines or by having had COVID is an area of active study, as I think I mentioned earlier. And the other concern is that even if the new variants can't evade immunity, do you need a greater number of the population to be vaccinated, in order to get control of the pandemic? So this is also, that development of herd immunity, as I talked about. So this is also certainly an area of active study, and like everything with COVID, in a state of flux, it's like stay tuned because the information may change tomorrow or next week. Moderna and Pfizer are studying, the idea of booster doses of their current vaccines and whether a second generation vaccine against certain variants might be needed. So, people are revving up to think about whether these kinds of supports to the current vaccines might be needed. Next slide, please. So what are the next steps? If you haven't, my encouragement is to get vaccinated. And people say, well, which is the best one? The best one is the one that you can get now. So, get on and try to get an appointment if you haven't already. And once you get your first appointment, if you happen to get Pfizer or Moderna, they'll schedule your second dose appointment at the time of your first dose. So anyway, get vaccinated, but then still continue to practice what we affectionately call the core 4, which is social distancing, using healthy hand hygiene, either hand sanitizer or washing your hands with soap and water for 20 seconds, using face coverings appropriately and covering your nose and your mouth, and staying home if you're sick. Next slide, please. This slide just shows some of the pictures that are available on social media. I just want to point out the upper left slide, that picture, the individual in the middle in the orange vest is actually our Commissioner of Health, who was at the August Martin High School vaccination pod or point of distribution. And the slide in the upper right, I believe, is from the South Bronx Educational Center. And one of those masked individuals works at one of our regional offices. So the EI staff have been actively involved in serving at vaccine pods. I worked at several of them and gave vaccinations. So I not only got the shot, but I gave the shot. And you can see the other two graphics are just from some of the flyers that the health department is giving out. Any questions?
Thank you for that, Kathy. And I just want to say that the person standing next to the man in the red vest is Patricia Pate, who actually is our director of oversight, who runs that pod in Queens. And our staff have been wonderful. We have all been contributing to the response efforts, not only to EI, but also to the community at large. So we really encourage everybody to get vaccinated and to, help us, crush the pandemic. So thank you, Kathy. And Kathy has really split herself in two, being EI's medical director, as well as doing a clinical operations for the department. So thank you for that wonderful presentation.
Yes, thank you. All right, now we will have Dr. Mary McCord, Director of Pediatrics at New York City Health and Hospitals Gotham Health, Clinical Professor of Pediatrics at New York University. And she'll be presenting on the update on H&H referral and bidirectional communication projects.
So, good morning, everybody. This is an update of the same process that was presented at the last meeting. And I just wanted to let you guys know where we are. As you may remember, this is an effort on the part of Health and Hospitals to organize our EI referral across the system in a way that will allow us to better track referrals, whether they were successfully, what happened to them, which will then enable us to follow up better. And as the adage goes, if you can't measure it, you can't improve it. And right now we can't measure it at all. But who's referred, where they are, we rely on the parent coming back to tell us the status of the referral. And so we hope that this is going to help us improve working with our providers to do a better job of identifying kids who might need referral and referring them, and then help us once kids are referred with encouraging families that may meet some barriers. So this is starting with a funded project that is addressing early childhood, prenatal and early childhood in a global kind of way. And EI referral is one of the focuses of that project. The initial sites are Queens, Gouverneur, and Bellevue, and those are the ones we're focusing on because they're part of this funded project. But a number of sites have expressed interest in the EI referral process that I'm about to describe. So Kings County, Harlem, and Jacoby have all referred at least some kids, and you may see more broad uptake across health and hospital sites as people learn about this and also as we improve it a bit. Next slide. So the goal, as I said, is to improve the follow-up by creating a mechanism that allows us to track whether referrals that were made, which provider or which team made them, and then to get reports back from early intervention about the status of where we have consent, about the status of those. It's based on us having an electronic method of initiating the referral that then allows us to send information to you and get information back. So there's a bi-directional sharing of information. So that's basically it. And then the tracking is part of the process also. Next slide. So I wanted to just briefly describe this. It's a little bit complicated, but the prior process was there was a piece of paper and we had to find that piece of paper, and we have thousands of providers across the system. And so every provider knowing where that piece of paper was for them was sometimes a problem. And then we had to find a working fax machine. We had to fax it. We had to stand by the fax machine to make sure that that's over. So my point here is that it was cumbersome before. It's a little cumbersome now, but we get this benefit of the bi-directional sharing of information. So the PCP, the primary care provider, identifies a child that's in need of referral, discusses referral with the parents, and where they're in agreement, makes a referral. They get request consent for sharing information, which in general, if we ask for consent, we get it. There is sometimes a problem that we don't ask for it because we forget that step in the process. But we try to get consent, and we that's a separate piece of paper signed, uploaded into the record, and we log it in as consent on file in a way that's open to tracking and auditing. The PCP then makes the referral through Epic. So you get it as a fax, but we initiate that fax within our EMR, which is called our electronic medical record, which is called Epic. And we document that consent is there, if it is there. And then each month we are sending Bureau of Early Intervention a report that summarizes all of the referrals made at the various health and hospital sites, when those referrals were made, and then we get back from you a report on each of those children. What's the status of those referrals? Each site goes to a central point to send out the report, and then when the report comes back to a central point at health and hospitals, we forward it out to the different sites. And it's the responsibility of each site to work with their care team, to make use of the information back and follow up with providers. Next slide. This is what it looks like. The fields in red do not obviously fax over in red. And in fact, they no longer print in red because they were not faxing over legibly. But this is the material that's there. But you know what? This is an earlier version. It's not the most recent version because I wanted to include the one that had, and I'm sorry about that, that has the health and hospital. So it's the one that we're using now. The top line says early intervention program, and under that it says New York City Health and Hospitals. So that allows you to identify it's one of the referrals on our site. And I will acknowledge that if you look under family information because of how the electronic medical record works, in many cases, we don't have the mother's name on file in the computer. Unless if the baby was born at health and hospitals, we do, but if not, we typically don't. We have the guarantor for insurance, we have the emergency contact, but we don't always have who's the mother. So sometimes the computer doesn't pull that in, the provider has to write it in, and we've worked on a process to remind people to make them stop at that so they fill it out. Next slide. So we initially began rolling this referral process out in the end of September, really beginning of October. We have regular touch bases between the early intervention team and the health and hospitals initiative leadership. We talk to each other at least once a month, I think. And we have just begun to get the reports back. So we sent a March report, a February report, and we got that information back and farmed it out to the sites. And we just last week sent the April report. And the other way, we sent the April report. Anyway, we're on our second month. We're getting the months straight. We just sent the second month's report, and we're looking to get that back soon. We are working on improving the process in our electronic health record because it's a little bit cumbersome, as I said. And we should soon be able to have a PDF version of the referral form, which may look a little bit better on your end and which is going to work better technically on our end and will allow a hard stop in fields like the mother's name and phone number that obviously have to be filled out. And once that's all done, then we have that improved version. At that point, we're going to start more actively encouraging other health hospital sites to participate. I think Dr. Parasami has tried this once or twice and can probably testify to the fact that there's a little bit of a learning curve in the 1.0 version what each different step is and how to do it. Once you learn it, it's not that bad, but there's definitely a learning curve. We hope that version 2.0 will be a little bit easier for people that are new to it to uptake it. And I think that might be the last slide. Next slide. Yeah. So any questions or comments or suggestions for us as we move this forward?
Dr. Periasamy, I thought you had a hand up. No?
Yeah, I just wanted to confirm that we have been using 1.0 version. All the residents are using it, which is good. Most of the fields are auto-populated, which is also helps. But we have not been receiving any report. There is to say that what is the follow-up of that. However, I want to point out one of the fax number in the Bronx is wrong in the form. So when we are trying to fax it, we got information that it was faxed wrong to the wrong number and wrong center. And we had to fax it again. I don't know if that can be looked at it.
Yeah, if you could send me, um, I wonder if that was in a prior version. There was one wrong fax number in a prior version, but can you send me the number that's wrong or pull up a referral and see if it's still wrong so that I can check if that's still true?
Sure, but the good thing is where we faxed the person in the EI center, they communicated with the provider to say, hey, you faxed it to the wrong place. Please fax it to the right place. So that was amazing.
Yes.
So one of the provider was very happy that kind of a communication happened, but pointed out like we need to eventually change it. I'm hoping that 2.0 will be better with the customer.
I think the issue was because I think I'm aware of every single referral that comes through as part of this project because we really want to get it right. And I think what happens is that sometimes the provider selects the wrong number and it goes to the wrong office. And so, but our referral teams at all of the sites are really on it. They're very supportive of this project. And so when there are little issues here and there, we call them growing pains. We're immediately communicating both with Mary as well as the provider just to make sure that everybody's on the same page. And I think that this is an excellent project for increasing referrals and for particularly from health and hospitals because you serve a more high-risk population. And so this is one of the ways that we are hoping to not only increase referrals, but also build in systems to improve retention. And so, because we know historically in EI, referral, yes, that is an issue, but retention is another issue that we've all sort of been thinking about and working on in our own areas to improve. So does anyone else have any questions for Mary on this project?
I raised my hand, but it didn't work. I agree with you, Lydia. I think this is a really great opportunity to be able to help families who may fall out of the system to kind of be connected. And I think that it would be really interesting, I think, to see if you chose a certain borough or a certain hospital and evaluate the effectiveness of the referral to service. And it could be a model that could be used future-wise in terms of looking at that.
Yeah, we agree. We are going to try and do that. And I will say that in terms of the information coming back, well, one, learning the new system, which is really not that hard, but then managing the information coming back in an effective way requires that you have staff that are able to do that. And it's an emerging idea in administrative circles around pediatrics that pediatric practices need to manage the population health of their kids. That a lot of peds practices have really been set up to give immunizations and see kids with fevers and asthma and not think in a population health way. So we're also working to advocate that there has to be some staff person who's got some amount of time allocated to the job of following up when these reports come back.
Kara, did you have your hand up?
Yeah, I was just going to comment similarly to Chris. I think it's this project shows a lot of potential for improving the retention rate, and I think it's really important to analyze that retention rate and maybe compare it to that cascade or the waterfall data report that Nora develops every couple of months. But I also wanted to ask what the referral volume has been like so far.
We're really doing this mostly in 3 sites, and I think we have about 40 referrals with consent, right? So one of our problems is that we have to we might get consent. We do usually get consent, but we have to click a particular box that says I have consent in order to be able to send you the report. And we are working on that part of the process, but with consent, we have about 40 referrals that we're asking for information back from March.
This is a very new project, so you're kind of getting reports on it as we continue to develop it and refine it. So, our hope is with the new versions that H&H puts out, it will obviously be fully integrated or more integrated into various practices. But, that is still something that I think we're all working toward together.
One thing I will say remarkable to me is that there are many ways you can criticize the efficiency of this process, but the degree of enthusiasm for it is really remarkable. It's from you guys, from our funders, from Dr. Parasamy, who said, I want that, and picked it up before we were asking for people. So I think it's meeting a need, and we just have to keep making it better as we build it.
I think so. But I think what Chris and Kara are saying is right, that we need to measure the effectiveness of the project. And I think that once we sort of get it more on the rails, we will definitely start thinking about, what an evaluation may look like. But we're not quite there just yet.
But using that waterfall data as a comparison is a good idea.
Yeah. As a baseline, absolutely. Okay, all right, I think we should move on.
Yes, thank you so much. Next we have Dr. Jeanette Gong, Director of Intervention Quality Initiatives, presenting on the BEI Outreach Activities and Service Coordination Professional Development Institute.
Good day, everybody. Next slide, please. To briefly review from the previous LEICC meeting, New York Bureau of Early Intervention had a consultant hold parent and service coordinator supervisor focus groups in February and March 2020 to learn how to better engage and retain families in New York City early intervention. BEI wanted to understand the factors that influence Black families' involvement in the program, to identify potential barriers to referral, and to determine areas of involvement needed. Today, we'll be presenting several projects we developed based on the information we learned from the focus group. So just to give you some of the highlights from the feedback we got from the focus groups, the parent focus group shared that there's a need for service coordinators and therapists to improve collaboration and partnership with families. The parents are worried that their children will be subjected to biases by therapists and service coordinators, that service coordinators call them every other month to check in, but they never ask parents how they're doing or about any new concerns, and parents perceive the EI process as just too confusing. In terms of the service coordinator supervisor focus group, service coordinators wanted more effective supervision, better provider technology, and more professional development training to help them to be better prepared with working with families. Most service coordinator trainings focus on administrative tasks, but not on how to work with families. And service coordinators feel a real pull and push between completing paperwork for their agencies and focusing on families. Next slide, please. So BEI developed these projects to address these issues, and we'll present them to the LEICC today. The first one is the Service Coordination Professional Development Institute, or as we lovingly call it, the SCPDI. Second is the Text to Service Coordinators Program. And the third is outreach to community partners and to parents. Dr. Patricia Gray from Hunter College will now present the Service Coordination Professional Development Institute.
Thank you, Dr. Gong. Good afternoon, everyone, and I am so happy to be here talking to you about our SCPDI. With New York City Early Intervention, we partnered together to create the Service Coordination Professional Development Institute. The focus is to support service coordinators' engagement and retention of EI families with a focus on implicit bias, cultural competency, family-centered, and reflective practices. In the first series of training, the emphasis is on enhancing service coordinators' connection and rapport with families. So thank you to the New York City BEI Race to Justice Group and the LEICC Service Coordination Committee for their review and recommendations on all the training content. We jokingly talk about how long our slides are, but we know that it's a lot of work and we're looking forward to it. So let me show you or talk with you about the 4 trainers that we're having moving forward. Johonika Kochi. She is the infant and early childhood mental health specialist with experience spanning several regions of the United States. Ms. Kochi is the director of the Institute for Parenting at Gordon F. Derner School of Psychology at Adelphi University. Ms. Kochi is performing the family-centered best practice training. Tanya Spence. Tanya Spence is a clinician, educator, and leader who believes she can strengthen the field through developing leaders to have a diversity, equity, inclusion, and belonging lens. She refers to it as DEIB. She is the infant mental health specialist consultant, leadership development, and trauma expert for MPG Consulting and the Senior Director of Early Childhood at the Jewish Board. Ms. Spence will teach the Connecting Families using culturally relevant service coordination training. Ms. Jackie Chasen, she's a social worker, she's a licensed clinical social worker, and she works at Emilia Kids. Ms. Chesson has worked in early intervention as an interventionist and evaluator and has been a child, family, and school social worker for the past 12.5 years. Ms. Chasen will conduct 2 of our trainings. She will do the Engaging and Retaining Families in Early Intervention and the Advanced Service Coordination Supervision training. And I'm Pat Gray. I'm the Director of Continuing Ed and the Interim Director for the Field Education Department for the BSW program at the Silberman School of Social Work. And I represent Silberman as part of the New York City BEI Academic Partners. I will teach the fundamentals of effective case management in service coordination and empowering families and caregivers of special needs infants and toddlers. Next slide, please. One of the most important things that we've talked about is evaluation, and the previous discussion really stimulated it and showed that BEI is really concerned about evaluation. So our evaluation plan for the SCPDI trainings includes that we're verifying all of the training attendance. We're completing pre-tests, we're completing post-tests. We're doing the completion of the training evaluation, and 6 weeks after the final class that the SCs have taken, they will get the post-training survey. After that, they will get the certificate of completion. We should also let you know that CEs and CTLEs are also available for participants to support licensure or certification, because we want to ensure that we're meeting the annual requirement for professional development as per the state providers agreement. Next slide, please. So what we've provided here is a schedule of all 6 trainings. Please note that every provider agency will be emailed the flyer. In addition, New York City BEI plans to email service coordinators directly and invite them to participate in the trainings. The flyer contains a description of each training, and we will follow up continuously with the participants who are training. I will now turn back the presentation to Dr. Gong.
So during the pandemic, Text to Families program was one way BEI shared EI updates with parents. Therefore, another way to support the work of service coordinator is to provide them a texting program where they may receive timely updates and information about New York City EI policies and procedures, regional office closures, upcoming trainings, and tips and resources about working with families. An email will be sent to EI providers, service coordinators, and the New York City BEI staff to identify the informational categories to include in this texting program. BEI invites everyone to help us find a name for the service coordination text messaging program by completing this survey. We really want to hear from everybody, and we hope that we do find a really attractive name for the texting program. So the next part of my presentation is going to talk about what we're doing in terms of outreach for 2021 and what we've done for 2020. Next slide, please. To increase referrals to the early intervention program, the outreach unit headed by Ms. Shirley McLean created additional resources to ensure that community and health providers knew that early intervention is an essential program, is open, and how EI referrals can be made efficiently. They also created a remote presentation about the program, and they focused on calling, emailing, and conducting remote presentations to community partners to assist them with making referrals, understanding the EI process, and that EI services were safe and effective, and addressing any misperceptions and questions about the program. Next slide, please. This table shows the different types of organizations that the outreach unit connected with during 2020. They range from childcare to medical providers, WIC, libraries, insurance networks, Department of Homeless Services, medical rounds, and other community organizations. In 2020, outreach was able to reach a total of 349 individual organizations and 1,591 people. Next slide. In terms of outreach plans for 2021, BEI will expand outreach to community partners to increase referrals via remote presentations that focus on engaging community partners to make referrals to the program, a part of the organization's regular processes, and will follow up to support and assist these community partners in implementation. The outreach unit will also support BEI's retention efforts by offering information sessions to all newly referred families using Text to Families. In Text to Families, presentations are sent to all the families that are just referred, and they can click on a link in the text messaging to register for these presentations. Presentations provide an overview of the process and addresses issues of stigma and myth about participating in the program that includes a question and answer session. In addition, New York City BEI is currently planning a social media campaign to support referrals to the program, a Google ad buy to support internet traffic flow to our New York City Early Intervention website, and placement of the 6 EI videos to ensure that families seeking information about the program can easily access them online. Next slide, please. Lastly, I want to share with everyone today about this very exciting project that our Developmental Monitoring Unit has started in January 2021. In collaboration with the Office of Vital Statistics, birth certificate information is used to identify those families with children who should be known to early intervention and who know about early intervention program as a resource. Children automatically eligible based on a diagnosed condition such as micropremies, Down syndrome, cleft palate, should know about EI and receive a full evaluation. This project offers direct outreach to families with children born at New York City hospitals who have an EI auto-eligible condition reported on their birth certificate, but who have not been referred to the program as of yet. And that's our presentation for today on some of the initiatives that we're doing in the Bureau of Early Intervention. Are there any questions?
Chris, you have your hand up.
Yeah, I just had a suggestion in regard to the training for the service coordinators and the evaluation process. I'm wondering if there's some way that you can get some feedback from families in regard to how they see the service coordinators after they've been trained. I don't know if that's possible or not, but I think clearly that would be one measurable achievement, is that you would want a better engagement from the service coordinators with the families. And like I said, it may not be easy. It's maybe something to think about in terms of how you can evaluate if families see a potential difference in terms of service coordinators and their response they get after the training.
That's a good idea. I think that the other way to measure the effectiveness of this is to just measure retention. So if so parent perception is one thing. I think it's obviously important, but if we really are trying to make a dent, we're expecting to see fewer families fall out of the process after referral. So that's another. So the idea is hopefully we'll just see it in our regular waterfall data, and we should also at some point talk about how, at what point, if it's available, at one point we would want to require it for certain agencies who may not be doing a super great job at retaining families. So those are kind of ideas that are on the table, but I think a family perception idea survey is something that could be added. Roseanne?
I just wanted to mention, Jeanette, that was a wonderful job about the outreach, and I feel like you're doing such a terrific job of meeting these different community organizations. I did want to mention, so you had started with United for Brownsville a while back, and I just wanted to say that, we have been a little bit involved with them and continue. They have hired a full-time person who's going to assist families in kind of navigating this whole early intervention process. And she's done a great job of meeting with various providers and getting some education about early intervention and how it works. And so I think that's going to be, in the future, going forward, a really valuable, also, community resource.
I'm glad that you mentioned that because our head of our outreach unit actually meets with Aileen on every 2 weeks to talk about early intervention, to talk about what we can do to support her efforts in working with families. And she's also working closely with the Brooklyn Regional Office. She's met with them as well, their schedulers, their referral unit, and their administrative director of the Brooklyn Regional Office. So we still working very closely with United for Brownsville, and we're working very closely with their family early intervention ambassador.
I think at the next LEICC, we've been, and Liz and I talked about this, we're going to have a full update on the United for Brownsville efforts, because they're actually one of our key community partners, and they tend to drive how we structure our outreach. And we think that that is a very good approach, because we want to be community driven in our various strategies and outreach efforts. But thanks, Roseanne, for that plug. And I'm happy that you're meeting with the United for Brownsville. That's excellent to hear.
Yes, it's wonderful.
Mm-hmm.
And also I want to thank Roseanne for all her comments on the SCPDI trainings.
Thank you, Roseanne.
Yeah.
You're welcome. Thank you.
Okay.
All right. So, I'm sorry, Lydia.
No, go ahead, Liz, please.
Okay. All right. Next, we will have Caitlin Moore, EI Transition Manager at the Division of Early Childhood Education at the New York City Department of Education, presenting on Early Intervention Transition Initiative and Document Transfer System, the DTS implementation.
Hi, everyone. Nice to see everyone today. I'm going to do my best to get through this really quickly because I know we're close on time. So next slide, please. So we're going to start with some early childhood general updates, which are really exciting. Next slide. So I'm sure many of you have heard the exciting news, but we're really excited to announce that Mayor de Blasio and Chancellor Porter just announced on March 24th that 3K for All will be expanding to the remaining 16 community school districts for the coming school year. So this will bring free full day, high quality 3K for All, which is for our 3-year-olds in New York City, to every single school district in the city. We made a chart that shows where we were this past school year and then for next school year where we will be. So as you can see, it will require a tremendous amount of growth. So families who are born with children who were born in 2018 can start applying now. The 3K application will be open through May 28th, and programs in all of these districts will be added on a rolling basis to our application system, My Schools. So next slide. Then I just quickly wanted to go through some of our early intervention transition work. As we haven't met in a while, so just wanted to refresh everyone that our team of transition coordinators has moved from supporting families just in the Bronx to supporting families citywide. In this role, the team supports families by responding to our email and helpline, which is at the bottom of this slide. They conduct proactive outreach to families who are transitioning from EI, and they act as a resource and meet frequently with the CPSC regions and EI regional offices. And most recently, they've been providing workshops for families and staff on inclusive preschool options and EI transition. Next slide, please. So just wanted to provide a really quick update. Our transition coordinators began doing some proactive outreach to EI families across the city on how to access services and preschool options. And so far, the team has contacted over 1,100 families by phone, text, or email, and we've had about 1,500 successful engagements. Note that the team often will engage with one family multiple times, so that explains the discrepancy in those numbers. And so what we learned is that many of the families that we speak with will submit referrals after we speak with them. They will also decide to apply for 3K, which is something our team can help with. And many families have raised questions about the difference between in-person and remote evaluations, how 3K and the CPSC process interact, and what inclusion looks like. Next slide. We also wanted to just quickly update you all that starting March and through April, we've been launching some free virtual information sessions with the Beyond Access series with the Special Ed Office on inclusive preschool options and the CPSC process. And in the sessions we've hosted so far, we've had over 350 families join us live. Recordings will be available on the Beyond Access series YouTube page. And for those of you who don't know, the Beyond Access series is a series of family information sessions that the DOE Special Education Office has spearheaded. We have some updated, with the success of these sessions we've had so far, we have some updated dates. We will circulate this information with the group, but we have some upcoming sessions in May. And thank you to DOHMH who really helped us promote these sessions through text to families and partners like Include, who distributed this information to the families they support. Next slide, please. We also partnered closely with DOHMH to offer information sessions for DOHMH EI staff, including staff from regional offices, developmental monitoring, central office, quality assurance, and the evaluation standards unit. We had over 135 DOHMH early intervention staff join these sessions. And in these sessions, we discussed inclusive preschool options like 3K and pre-K for all, and how to access services through the CPSC. We plan to roll out a similar series of info sessions for early intervention agencies and service coordinators, hopefully in May. Next slide, please. As a reminder, the document transfer system launched in August, and this is our one-way document transmission service that one-way document transmission system that has replaced the fax between DOHMH Early Intervention and DOE. And this is where EISCs upload documents and input key child and family information. Next slide, please. Just wanted to do a brief update on when we had last met in October. We had just recently launched the system in August. So did want to show the growth in the amount of documents that we have submitted through this system between October and now. So as you can see, the total number of documents, notifications, and referrals transmitted between October and now has grown tremendously, and we're really excited to see that. Next slide, please. And that's it. I'd be curious to see if anybody has any questions on the 3K expansion or on our early intervention initiatives.
Chris, you have your hand up. I don't know if it's from before.
It's from before, but I would just say I think there's some concern among the preschool special ed providers in regards to referrals and other issues facing the schools. Many of the schools right now have or are under enrolled because of the drops in EI referrals and other things. And there is some concern around the expansion of 3K for all, and that our teachers are still not included in the salary parity agreement. And a number of the schools are really interested in getting referrals for kids. So I think I just want to let you know that there is some concern out there in the field right now. While everybody supports the expansion, I think there is some concern that there may be more children, referred to 3K for all, and it could impact the numbers of children referred to our programs. So just to be aware of that in terms of if you hear that from people.
Thank you very much for raising that, Chris. I'm going to pass this question actually to Jessica Wallenstein.
Thanks, Caitlin. Yeah, Chris, thank you for raising this. We are aware of the enrollment challenges that the non-public sector faced since the pandemic hit. We've seen enrollment down in 3K and pre-K programs as well. So it's an issue across the board. Really happy to see in the state budget that the Hold Harmless Amendment made it in when it comes to 4410s. And we're, obviously supportive of that. We're also, right before the pandemic hit, the DOE made it one of our legislative priorities to advocate for a state rate increase for 4410s. And so, we're still hopeful to see something in the administrative process. And then I would also just say, we are exploring ways that we can keep working with the sector as the current city budget process is still in play. So just know that it is top of mind, and I look forward to working with you more, Chris, as 3K rolls out, and as we will continue to need and rely on and want to support 4410s, because we will need your programs to continue serving many of our students with the most severe disabilities. So I just want to say I hear you, and a lot is still in play right now.
Yep, sure. Thank you.
Mm-hmm. Any other questions?
Trisha.
Yeah. Hi, actually, this was to follow up on Chris's comment. If you could just say a little bit more about the barriers. It sounds like for referral of children in either 3K or UPK. And again, was that because of just if they're not registered, or I just want to be sure I'm understanding the concern, because that directly impacts us at the CSE.
In terms of, I think there's like sort of two sort of thoughts. I mean, I think one is that we have heard from some of our providers that there still seems to be some delays in terms of getting children through the whole, evaluation process and the meeting and getting the placement. I think the other dilemma that's facing a lot of providers right now is that the requests that are coming in are for children who need class sizes of 6s and 8s. Who have high levels of need, and most of the empty seats right now are class sizes of 12. And so I think the real big concern is that as the need and the increased numbers of kids come, is the system going to be able to meet the needs for children with this high level of need for very small classes? And I think that's one of the concerns moving forward.
Got it. Okay, so it's more about the placement of children potentially if a small class need is there. Okay, thank you.
Yeah, Chris, I think we should also just connect on the possibility of conversions so that those 12s can turn into 6s and 8s. And, you know, we are trying to ensure that regional need data is up to date. There's a new posting that just went up. And then there'll be another posting for September that will hopefully be supportive of what you're seeing on the ground. And I'd be happy to partner with you to make sure the state is responsive to those modification requests and
Okay,
issues.
great. Yeah, we'll definitely be in touch then. Thank you.
Any other questions?
I don't see any other hands here. Okay, so now we will have committee reports. Does the Academic Preparation and Professional Development Subcommittee have anything to report?
No, we have nothing new to report since the last LEICC meeting. We're still working on finishing the fieldwork placement manual.
Thank you, Jeanette.
You're welcome.
And does the Service Coordination Subcommittee have anything to report?
Yeah, I will just say that we reviewed and provided feedback on the 6 modules for the Service Coordination Professional Development Training Institute. And the subcommittee reviewed and provided feedback on the transition training content and the developed resources. So the committee has reviewed a lot of the materials.
Okay, thank you so much, Chris. Okay, so now we will have public comment. Were there any public comments submitted?
No public comments were submitted.
Okay, so there are no public comments for the record. And at this time, I would like to thank all of you for participating in our meeting at the LEICC, and it is now adjourned. And please stay safe and healthy, everybody, and we will see you next quarter.
Thank you, everyone.
Thank you.
We'll be in touch.
Thank you.
Bye-bye.
Bye. Bye-bye.